Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling osteoporosis. So as always, let's kick it off with our practice question. The nurse reviews osteoporosis self-management with a client. Which of the following statements by the client indicates an effective understanding? Select all that apply. We have A, I should plan exercises that involve resistance bands. B, I should wear shoes with non-slip soles. C, I should eat a high phosphorus diet to help strengthen my bones. D, I will need a repeat DEXA scan to determine if the prescribed medications are working. Or E, osteoporosis puts me at higher risk for a fracture. Again, choose everything that indicates effective understanding. Okay, tuck that answer away. Of course, we will circle back to the correct answer at the end of the episode. But first, we're going to talk all about osteoporosis. And to really understand it, we have to start with how bones work. Bones are not just hard, static, skeletons. They are living tissue that are constantly being remodeled. Honestly, you can kind of think of your bones like a construction site that never closes. We have two key teams on this construction site. Our osteoblasts, which are the builders making new bones. So B for blast, B for build. And then we have our osteoclast, which is the demolition crew that is breaking down the old bone. So our blasts build and our clasts break down the old bone. And in a healthy adult, these two teams are working totally in balance. Demolition and rebuilding are happening at about the same rate, which keeps bones really strong and stable. But in osteoporosis, that balance gets thrown off. The osteoclasts, that demo crew, get way too active and they start breaking down bone faster than our builders, the osteoblasts, can rebuild it. So over time, the structure of bone gets thin and brittle. It's full of these tiny little holes, honestly, kind of like an old weathered building where too much has been torn out and not enough reinforced. So let's actually now back up even farther though, because who's in control of these workers? Who's the manager at this construction site? And it's our hormones, all right? Hormones are really big here, especially estrogen, parathyroid hormone, that's our PTH, calcitonin, and vitamin D. Let's go through each one. So first, estrogen. That is going to keep bone resorption, that breakdown, in check. When our estrogen levels drop, for example, after menopause, a very normal time in a woman's life, the osteoclasts are going to lose their regulation and start chewing through bone more aggressively. So estrogen down, the clasts really ramp up and we break down more bone, which is why post-menopausal women are the highest risk group for osteoporosis. Next are parathyroid and vitamin D. These two work together to regulate calcium and phosphate levels. So both of these are really key building materials for bone. If calcium is low, then parathyroid hormone basically pulls it out of the bone. Like, hey, I need to come borrow this calcium that you have stored up so that we have enough calcium in the blood to keep our other systems running. Okay. So low calcium in the blood triggers parathyroid hormone. That parathyroid hormone goes and takes it out of the bone. Okay. So we don't want to have low calcium levels. Otherwise, parathyroid hormone is going to kind of steal it from our bones. Now, lastly, calcitonin is a hormone made by the thyroid, and it's kind of the opposite of that parathyroid, basically to keep it in check. Instead of taking calcium out of the bones, it helps lock calcium into the bone, slowing down resorption. So you can basically just remember PTH is going to take calcium out of the bone. Calcitonin is going to lock calcium into the bone. So obviously we need to have these in check to keep the right amount of calcium in the bones so that they're good and strong and healthy, and they're not just gonna, snap like a twig if we have a minor injury. Everything really has to stay in that perfect balance. If we have calcium or vitamin D intake too low, or hormones shift, or, also if there's a lack of healthy weight bearing activity that stimulates the bones, well, that construction site gets all wonky. The demolition crew is going to be taking things down faster than the builders put it up, and our bones get really weak. Now, I just mentioned this weight bearing activity. That's a kind of a non hormone component here, but it's really important. Our bones get stronger when they are used. So, anything weight bearing, walking, dancing, lifting weights, like literally walking around your house, signals the bones, hey, we're being used. We need to reinforce ourselves. We need to stay nice and strong and dense. Let's say someone's on bed rest. They've had an injury. They're not able to get up. That can happen in our elderly population, and they lose that stimulus of weight bearing activity that tells the bones, hey, we need to be strong. So they don't, they become really brittle, losing their density even faster. So, all that being said, what do we do about this? Let's go into our case study for the day and talk through a client, 67-year-old Miss Thompson. She is a retired teacher and she's in just for her annual exam. All right. So, first thing, whenever someone comes in, whether you are in the hospital, long term care, outpatient, whatnot, you are assessing them from the moment you see them in the room, the clinic, etc. And on your kind of across the room assessment of Miss Thompson, she is moving slow, kind of hunched in her upper back, easing herself into the chair. Not uncommon for somebody who is in their 60s, late 60s, early 70s, but you want to ask some questions about that. You ask how she's feeling. She's saying, I can't get around like I used to. I feel like I am shorter than I used to be. And you see how she's kind of hunched over. That is a key finding, a key little nugget takeaway about osteoporosis is we can have clients literally shrink. Height loss is a red flag that tells us bone density could be going down and our vertebrae are literally getting closer together. So we're losing some height. Obviously, we need to ask some more questions here. We want to ask about back pain. She does have some back pain after bending over. She's not had any falls or traumas, but she has noticed that back pain. Now, pause here. Would that make you concerned about osteoporosis? Why? Well, basically, let's think we have a woman in her late 60s. So she has gone through menopause. Her estrogen levels have dropped. And remember, estrogen acts like kind of a brake on that construction crew that is knocking down our bone, those demolition workers. So when we drop in estrogen, those osteoclasts are going to go into overdrive and they are breaking down bone faster than the osteoblasts can rebuild. So when that loss in bone density first hits, it's going to hit the spines, the hips, and the wrist. Those are areas where bone turnover is already really high. So bringing this back to Miss Thompson here, her shrinking height and her back pain, these are not normal signs of aging. These are the result of tiny vertebral compression fractures caused by weak and brittle bone. It's the support beams of our building, slowly giving way one by one. Okay, so there's your first two signs, that shrinking in height and that back pain. All right, those bones are getting weak. And what we are going to do to look further into this is called a DEXA scan. This is the gold standard for measuring bone mineral density. We basically want to see how strong, how dense are these bones. We also want to get some lab work, thinking back to who controls everything here. We want to look at our hormones, we want to look at that calcium, that vitamin D, etc. So we get our results back for Miss Thompson here, and the DEXA scan did show decreased bone density, so that's consistent with osteoporosis. And then lab work, we have normal calcium, but a low vitamin D. Okay, vitamin D helps the intestines absorb calcium. So when we don't have enough vitamin D, even a calcium rich diet isn't going to do the trick because we're literally not absorbing all that calcium, getting it into our blood and therefore our bones. Okay. So once we confirm this diagnosis of osteoporosis, what do we do? All right, first and foremost, first med you're going to need to know is a biphosphonate. So in this case, we're using a med called aldendronate. It's our most common biphosphonate. If you see a drug on your exam, it will probably be that. And what aldendronate does is inhibit osteoclast activity. So basically, that demolition crew that is breaking down bones, we're gonna, tell them to go take a coffee break and pump the brakes on all this breakdown. That gives the osteoblasts, our builders, time to catch up and go strengthen that bone structure. Now, we do have some nursing must knows about biphosphonate meds. They need to be taking it first thing in the morning with a full glass of water and staying upright for at least 30 minutes afterwards. Why? This med can irritate the esophagus. So if we take it at night, we lay down, we can get some reflux and some breakdown going on. Definitely not what we want to happen. So taking it with a full glass of water and staying upright is a key safety teaching point. Next med, we are going to add in some calcium and vitamin D supplements. The calcium will give their bones that building material, and the vitamin D will make sure that it gets absorbed so we can actually put it where it needs to go. So those are our meds. We're going to start a biphosphonate, calcium, vitamin D, easy enough. But we have some non-pharma interventions to talk about too. First, exercise. Remember, weight-bearing exercise, walking, dancing around the kitchen, whatever. Just putting weight on our bones tells them, hey, we need to activate those osteoblasts and build up strong bones. We also really need a safety point here to put her on fall preventions because her bones are fragile. So even something small can lead into a fracture. So these are going to be, she's going home. So we need to look at her home setup, get rid of loose rugs, make sure she has good lighting, non-slip shoes, make sure we don't have any like cords across the kitchen, ask if she needs to go up and down stairs to get to the bathroom. These are the big things, and they are going to protect against injury, which is the biggest risk of osteoporosis, right? Getting a fracture. Now, lastly, we are going to keep repeating that DEXA scan. Usually it's about every 1 to 2 years, and we're just checking in on that bone density. We want to see if it's improving because that will tell us that her meds are working, that we are slowing down those osteoclasts with the biphosphonate, and we are giving the bones the materials they need with that calcium and vitamin D. And that's really the key takeaway, helping find that balance between building bone up and slowing that breakdown down so that we get stronger bones. And with that being said, it brings us right back to our practice question. Let's review and see now if you get to that right answer and understand why. The nurse is reviewing osteoporosis self-management with a client. Which of the following statements indicates effective understanding? Select all that apply. We have A, I should plan exercises that involve resistance bands. B, I should wear shoes with non-slip soles. C, I should eat a high phosphorus diet to strengthen my bones. D, I will need a repeat DEXA scan to see if my meds are working. Or E, osteoporosis puts me at higher risk for a fracture. Go through each one like a true or false question. Tell yourself yes or no. Would that statement indicate effective understanding? What do we think? A, B, D, and E? All of those show a solid understanding, okay? We are doing weight-bearing exercises with resistant plans, putting in interventions that stop falls, those non-slip soles, repeating that DEXA scan so we make sure the meds are working. And, all of this, really important to know they're at higher risk for a fracture with those weaker bones. So A, B, D, and E, all absolutely correct. Now C, our incorrect answer, is the outlier here because phosphorus isn't the goal. In fact, high phosphorus diets can really pull calcium out of bones. If you remember back to our fluids and electrolytes, calcium and phosphorus have an inverse relationship, kind of like a seesaw. So if phosphorus goes way up, that's going to push calcium down. We really need to emphasize the calcium. That's why we started a calcium supplement. And remember, we also need to complement that with vitamin D so the calcium can actually be absorbed. All right, so key takeaway to end the episode here. The management for osteoporosis is about building up that bone strength and preventing injury. They are going to be at a higher risk of a fracture, so fall risk should be in place. To build those strong bones, we want to move our body, do weight-bearing exercise, nourish with calcium and vitamin D. And the key med that you'll remember is that biphosphonate to slow down our osteoclasts so they stop breaking those bones down too fast. With the right habits and these medications, the bones may weaken, but we can really slow that down and promote a very high quality of life. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.